Dr. Diaspro, your lecture.
Thank you very much. Ladies and gentlemen, good morning, everybody. I would like to thank the organizing committee for the invitation. It is a great pleasure for me to be here, and as a surgeon, a big honor to share with you this few knowledge we're gonna face. Let me start wondering which you think is the biggest challenge you face daily in our office. Probably is to deliver to our patient, hopefully in a practical and profitable manner, the newest and most predictable evidence-based protocol. And a topic concerning the appeal of our therapeutic proposal drive us to face with a lesser time-consuming solution and the most aesthetic and comfortable results treatment may be able to guarantee. So let's have a seat at my table, because I'll give you some old good wine in a new bottle, as often happens with smart ideas. We must consider that patients are not attracted to our therapeutic proposal for scientific reasons. The promising results will be enthusiastically received by them just because they reduce total treatment time, or because they allow us to treat them comfortably in outpatient way instead of in a surgical theater. Historically, even if dental alveolar surgery was originally planned as an in-office alternative to orthodontic surgery, the German pioneers in the early 20s of the last century started working with osteotomies. And we must wait to the Americans' debate to appreciate the first interdental corticotomy cut, even if Cole, who published this paper, used to connect them with a subapical osteotomy, horizontal, aimed to move bony blocks instead of individual teeth. The literature published until the end of last century by authors worldwide has been merely anecdotal, and the rising innovation of dental alveolar surgery techniques has been evaluated in the context of the status quo instead of as a promised land. Fortunately, as the century closed, dental alveolar surgical orthodontics reached the end of talent-based medicine and began, supported by gratifying clinical results, its long scientific journey toward evidence-based medicine. The surgical protocol, too, were further modified in order to make them gradually less invasive, coming finally to flapless surgery. Fortunately, new ideas do not fit easily into old paradigms. And in fact, the major shift has been made on the rationale of the technique rather than of surgical approaches. We know that the dominant tooth movement paradigm in orthodontics is a periodontal ligament cell-mediated process. But it cannot explain at all the greater tooth movement which follow injury to cortical bone. Lab research related to this topic, of course, suggests in fact another explication. Secondary to alveolar corticotomy, a bony cell-mediated response around the tooth provides a favorable microenvironment for tissue remodeling. Namely, the regional acceleratory phenomenon described and published by an orthopedic surgeon, Frost, in the late 70s of last century, accelerate the appearance of macrophages that remove hyaline 1 week after initiation of orthodontic force. And this allowed early bone resorption and rapid tooth movement. These are fluorescent microphotographs showing bone labels on the tension side of second premolars. Picture A shows maxillary bone apposition in the control group, while picture B shows maxillary apposition in the treated group. And C and D are the same for mandibular jaw. It is clearly visible that accumulated distances between the bone level lines are significantly longer in the treated group than in control group in both jaws. The image was kept from the article I showed before. Then we should start to consider the limit of orthodontic tooth movement as defined by the space in between the periosteum and the periodontal ligament. Rather than modifying dentition to basal bone, it is now time to build a better bone to accommodate an idealized dental arch. And you, orthodontist, must define this available space, not just by a projection of a line and a upright dentition, but rather by the labial limits of the marginal gingiva and the bony wall of the alveolus. It is your duty to formulate and to coordinate the treatment plan. With your surgical partner, you get a chance to reshape and define novel and more stable alveolus phenotypes by means of dental alveolar surgery and modulating physiological internal strains. A clinical period follows the reactive demineralization after cortical bone injury. And this window of opportunity we have allows to move teeth rapidly through demineralized bone before it remineralizes. It used to last for 3 months, but can be extended up to 6 in orthodontically strained bone. This tailored treatment could be planned to accelerate corrective orthodontics, to facilitate the implementation of mechanically challenging movement, and to enhance the correction of moderate skeletal malocclusions. On the basis of this consideration, and with the aim of a further improvement of less invasive procedure, an innovative and simplified tunneling procedure combining piezoelectric cortical incision and bone tissue grafting has been conceived and will be here described now. This is the case of bilateral molar class 1 malocclusion, severe crowding, open bite, and reduced upper arch width. Cephalometric analysis confirmed an open bite with no skeletal components, and a cone beam computed tomography, we will call CBCT scan, was collected among all the conventional orthodontic and surgical diagnostic data to design the surgical assisted orthodontic treatment plan. In order to avoid the palatal surgical expansion, but to obtain a maxillary arch expansion of about 4 millimeters in the premolar region, with staging set at 0.25 millimeter per aligner, corticotomies were selected to assist the Invisalign orthodontic treatment, considering that they provide the advantage of increased alveolar width to support teeth and overlying tissues. The three-dimensional visualization of the orthodontic treatment stage permits a very precise surgery scheduling, taking all the advantage of the rapid response, and a total duration of 30 months of treatment was initially forecasted. The day when surgery was scheduled, a full-thickness vertical gingival incision were performed along the median and both in lateral frenula, using a number 15 blade, not extending it to keratinize gingiva. Full-thickness incision were made cutting the mucosa straight to the periosteum, allowing the blade to touch the alveolar bone. Then, with a sharp periosteal elevator, we go further, allow a wide subperiosteal tunnel dissection over the roots of the involved teeth, both mesially and distally from the incision we made. Then a dedicated piezoelectric angulated microsaw, designed and engineered to perform corticotomy through this surgical access without the need of endoscopic assistance, as published in the literature already, was introduced into the tunnel, created underneath the flap, and interproximal corticotomies extended through the entire thickness of cortical layer was performed with an established augmentation procedure according to literature in these cases. The vertical incision were sutured in muscular layer and on the mucosa to complete the procedure. Orthodontic treatment was resumed on the same day using Invisalign aligners. During the wrap phase, aligners were changed every 5 days, reducing of about 1/3 the normal protocol of aligner changing. This approach permitted to reduce the duration treatment forecast from 30 to 18 months. No dentinary hypersensibility, neither loss of tooth vitality, no adverse periodontal effect, neither significant reduction in crestal bone age, and no evidence of apical root resorption effect were clinically and radiographically noticeable during 12 months of follow-up evaluation. The postoperative CBCT scan, as you can see, the patient underwent after the surgery, confirmed the increased bone thickness in 1.3 to 1.5 region. It has to be clarified that the same surgical procedure was performed on the other side. Then another case is here presented. A class 3 patient with a dental class 1 malocclusion with anterior crossbite, 1.2 agenesis, and a previous orthodontic treatment conducted in order to close the upper edentulous space. Cephalometric analysis confirmed a class 3 skeletal malocclusion. Once again, in order to avoid palatal surgical expansion and considering the increased alveolar width corticotomies allowed to obtain, they were selected to assist Invisalign orthodontic treatment. CBCT scan was of course collected, and it shows, unfortunately, a critical circumferential bone loss in tooth 1.3, and we decided to treat it after the orthodontic maxillary arch expansion. Treatment was aimed to obtain a proper recovery of upper arch width and to open 1.2 edentulous space to allow a proper restoration, of course. Once treated, the circumferential 1.3 bone loss, and then to restore smile aesthetics. Aligners were changed every 5 days, reducing of about 1/3 the normal protocol of aligners changing, and the duration of treatment from 10 to 6 months. Follow-up evaluation was uneventful, and the CBCT scan showed an increased bone thickness in 1.4, 1.5 region, and the preservation of bundle bone labially to tooth 1.3. When guided bone regenerative surgery was planned around 1.3 root, we really had the chance to clinically appreciate that we really managed to define novel and more stable alveolus phenotype, preserving labial bone around a critical root by means of properly planned dental alveolar surgery and modulating the orthodontic strain. Once again, we have not to look for a merely faster orthodontic treatment with this technique. And here is presented the provisional restoration the patient is now wearing. Then, Incisalign technique has been conceived to overcome the referred complication of previously described surgical approach, to avoid periodontal damage, and to offer the chance to apply a unique surgical protocol, no matter the number of sites to treat in segmental or sequential approach, and the need or not to bone graft. From a merely technical point of view, it can of course assist conventional orthodontics too. But this is not a shortcut. Remember that if you look for faster solution, complication could come faster. And if you look for bigger solution, complication, unfortunately, if they will come, will be bigger. As in office procedure, Incisalign technique is very respectful of the periodontium. No circular incision are performed, even though a full thickness flap elevation is obtained with similar level of morbidity as another orthodontic-related surgeries such third molar removal, or gingival grafting. For sure, it carries lesser morbidity than orthodontic surgery. At the meantime, it's aimed to be user-friendly, being performed in a dental office, allowing soft and hard tissue grafting when required, and minimizing post-operative discomfort, reducing chairside time, of course. To date, these two are the only published report of Invisalign-assisted treatment with dental alveolar surgery. And in both of them, the treatment involves a segmental malocclusion. Therefore, the technique here presented has been submitted for publication. I'd like to conclude, colleagues, sharing with you all the awareness that treating patients, no matter which is our daily practice, it is a privilege and not a right. And this privileged position we have always demand excellence and not mediocrity. Thank you very much for your kind attention.